Hello and welcome again to the Early Career Physician Section interviews. I am very excited to be here with Lauren Fine, who is heading up the newest section of ACEP, the Reproductive Health Section. And there is a whole lot going on in this space. And I think my personal opinion that this section is based on a growing need within our specialty and community. So Lauren, thank you so much for coming here today and taking your time. Tell me a little bit about yourself and why you're getting involved in this section.
Sure. I am an emergency medicine physician practicing in Dallas, Texas. I work at the same hospital I was born in. Um, and I trained at Highland Hospital in Oakland, California, and after which I knew I wanted to come back home. I'm very close to my parents who are here and my siblings and, all the next generation, and I knew I wanted to come back. And it's been such a joy and a really interesting trajectory because when I started at my hospital, we have had GME since 1903, but we did not have an emergency medicine residency until 2021. And so I really practiced clinically at a level one, you know, privademic uh, medical center affiliated with Texas A&M's medical school. And then due to some really wonderful advocacy within the department, we petitioned and started a emergency medicine residency. So we now have a 3-year class, or 3-year program, 8 residents per class. And a lot was going on in the early 2020, 2021, 2022 timeframe. And in particular, 2022 was Dobbs. And we had a new program, and I already sort of had a niche in sexual assault care. I'm the founder and medical director of our forensic medicine program and involved in the forensic medicine section at ACEP. Um, and I knew that some of the care we provided was going to become more complicated, right? Pregnancy loss care, ectopic pregnancy management. And so I sort of saw a gap and leaned in, and all of a sudden, here we are in 2026 starting a section.
I think that's a that's a great summary of a whole lot of stuff
There's a
going
lot.
on.
There's a lot. We
Wow.
could spend an hour talking about the last, 4 years. So,
And I think probably people who are interested in this section are probably at least somewhat aware of big picture kind of what was going on. And Texas, especially one of the most restrictive states, different from my experience. I am in Ohio. We had a latent bill that was the heartbeat bill. So we had one of the most restrictive laws for about a year or two before we passed a constitutional amendment. So now pregnancy care, early pregnancy care in my state is very different than your state with many other implications, I would imagine.
mhm. And we also had a bill that was put in place a year before Dobbs. So um, I think that began the slide, but I think it continued to get harder I mean, honestly, to provide miscarriage care and to do some really bread and butter emergency medicine things like diagnose and treat ectopic pregnancies. One of the things that I think that's obviously like core emergency medicine is diagnose and treat an ectopic pregnancy. And when you learn that as a resident, it seems much clearer than when you get out into the real world and you're like, is this an ectopic pregnancy? Is it not? Well, it's not definitive if I don't see a yolk sac or a fetal pole. Well, we can't really wait for every ectopic to be a definitive ectopic because less than 20% of ectopic pregnancies ever get a yolk sac or a fetal pole. And
Mhm.
so, what happens when we inject fear around restrictive abortion laws into care for ectopic pregnancies is often delays and denials of care that are really antithetical to what we should be doing in emergency medicine.
Yeah. And one point that I want to make that is very intuitive to people very involved in this, but I think outsiders looking in don't always understand is that the idea of reproductive health care and managing miscarriages and all of the gray spectrum in between, that is where we lie in emergency medicine, and that is what this is all about. It's not about something that you just decide off your whim and you want maybe to end your elective pregnancy. This is about women having problems from healthcare and access to healthcare and saving lives of those women who experience those complications that are out of
Mhm.
their own hands.
Mhm. Yeah, I'm very comfortable sharing this story. I share it often, but I diagnosed my own missed abortion on a shift. I wasn't bleeding. I went in to just ultrasound myself as any, pregnant ER doctor does. And I had previously had
Probably
a
why they tell
heartbeat.
you not to.
Yeah. Whatever. Uh, so I had previously had a heartbeat. I was about 8 weeks pregnant, and it was my first pregnancy. And I went in to look, and all of a sudden I could tell that the heartbeat was gone. And I wasn't bleeding, so I wasn't expecting this. Like, I really, in retrospect, my nausea had improved, and, I was miscarrying. And uh, long story, at the time, my OB was still in California. And even by the time I got to go see her, I still had not started bleeding. And I was like, women should be offered all options by my OBGYN. And for me, as a young, healthy woman, a DNC going to the operating room felt like too much. Waiting didn't feel great because I was trying to start a family, and I still wasn't bleeding, and I really didn't know when I was going to start to miscarry. And then there was the medication option, and to me, that felt like I could have some agency over an undesired process. And was able to really sort of schedule my miscarriage on my own. Well, what day looks good for me to have my miscarriage? Because I'm not, missed ABs are kind of a funny situation because you're not pregnant anymore, but also like nothing's happening. Um, so I was able to do that. And after that experience, I was like, wow, that wasn't that complicated. Like, why didn't I learn that in residency? We take care, I think first trimester vaginal bleeding is like bread and butter core emergency medicine. We're pretty good about ruling out ectopics. We're less good at counseling women about pregnancy loss, even though I think we do it a lot.
Mhm.
And I think as a whole, we're not as good as we could be at offering options. And I think that if emergency medicine trainees can do a cricothyroidotomy, put in a chest tube, do CPR, then they can probably prescribe medication for pregnancy loss. So this idea that this is not within our scope of care, I hope is becoming outdated. And I really hope that this section helps us move into the modern world where we say, listen, this is within our scope of practice. We can do this safely. We know how to use ultrasound to make the diagnosis of pregnancy loss. It's not that much harder to offer medication management because these women often don't have anywhere else to go. You said that they come to us because there is nowhere else. And in
Mhm.
fact, many people don't understand that that is structural, that the big payout in obstetric practices is at delivery. And so obstetric practices have a disincentive to see women early in their pregnancy because one
Mhm.
in four to one in five pregnancies ends in pregnancy loss. They won't get that big payout. So there's just not enough space made, even for women who have an OB, to get in early in pregnancy when most miscarriages are happening. This is and will remain our scope of care.
Yeah. And in my experience too, the same thing. They're disincentived to see people early on, and they don't want that uncertainty. So usual OB appointments are 8 to 9 weeks because there is less uncertainty when they put the ultrasound on and see or do not see anything. So oftentimes I will come in, or I will have women come in who have bleeding. They had a positive pregnancy test. They have an appointment scheduled, but it's not for 4 weeks because that's when they want to see them. And then we're making the diagnosis. And there is a whole lot of uncertainty in some cases. And sometimes, unfortunately, there's not. And they still can't get in because they're a new patient. So they can't get in
Mhm.
2 days.
And there's just, I really just don't think these patients are leaving our emergency departments. If anything, it is going in the other direction, especially as labor and delivery units close across the country
Mhm.
and the maternity care deserts are increasing. This is only going to become more of our job. And we can either be ostriches and put our head in the sand and say, no, it's not. Or we can choose to take care of the patients that are coming to us for care. And I really truly believe that we are the right people to do this, to provide this care. There's really exciting work that's happening from organizations like TEAM. It's teaching education, advocacy, and miscarriage management out of the University of Washington. Kelly Quinley, who's a Cal ACEP member, um, is involved with that as well. And they're teaching all options miscarriage management to ERs across and joint ER obstetric audiences across the country, with a special focus on not only teaching medication management, but also teaching procedural management, which again, I'm going to posit that if you can do a cricothyroidotomy and you can do a chest tube, that you can probably also be trained to do manual uterine aspiration. For women who are having significant bleeding. And I think about all these ERs that, you know, they don't have any OB. You've got to transfer your patient hours away. Like, what if you could actually help that patient where they are? I think this is, for me, probably like a 10 to 15 year goal. I really think my low hanging fruit is like, let's do better at counseling and medication management. But once we've nailed that, procedural management for early pregnancy loss care should be within our scope of practice, in my opinion.
Well,
And I
and
think there's
certainly,
ACEP policy to suggest that as well.
I think there is some ACEP policy to suggest that. And certainly medication management, managing complications, usually our pain, usually our bleeding. We certainly do that every day. Well, I don't know the numbers, but the majority of miscarriage care is with medications, not procedures. But I see so many patients with the complaint of vaginal bleeding in early pregnancy, but I can count on one hand the number that have been sick as SH. And they are scary when you don't have the backup. You're putting
Mhm.
Trendelenburg, you're giving an emergency transfusion, you're giving all the hormones that you have to look up on shift because you haven't used them in a while. They're white as a ghost. Those ones
Mhm.
are scary. And I am so thankful I'm in a place where at least someone will come down to see that. But now, like you mentioned, maternity care deserts. I'm working at one rural hospital where the OB unit is closing. I'm not sure if it did or if it is in the coming months, but it might be closed right now. And there's so many more places. And even the legislative landscape where there are places where you have to transfer someone 8 hours for care. And if they're bleeding heavily, there's so much potential for risk in that transfer, more than the 15 minutes that I might have or the hour that I might have. And I
Mhm.
really, my long-term goal is that no one dies unnecessarily during childbirth
Yeah.
birth or pregnancy
Yeah.
complications. And I feel like you've got a little bit more of the ABCs of how to do that. And I love that.
Yeah. And, we actually are about to publish a paper in academic emergency medicine, and we looked back at 18 months of early pregnancy loss in our tertiary care level one Texas emergency department, where we've done a lot of work trying to get ER physicians feeling comfortable providing medication management. And some of the things we learned through that retrospective look at our data is that number one, those that we manage with medication actually had a lower 7 day return ED visit rate. I think there's a lot of hesitation. People say, well, I don't want to give this medicine if I don't have XYZ backup. They don't have follow up. But the truth is, the people who need follow up are the people with expectant management because they are less likely to complete on their own. They are more likely to come back. Those are the ones who need follow up more. And the other interesting thing is that despite our best efforts at trying to get our ED comfortable, um, providing medication management without a consult to OB, we were not successful there. And even I think OB wasn't offering intervention as often as they could be. And I think there's a lot to unpack. And of course, this is only experience of one center, so I think there's a lot of variability. But I think this tells us that we have a long way to go. And I found it reassuring to see that, you know what, when we provide medication management, you're less likely to need to come back to the ER. And I think we can all agree that unscheduled emergency care visits are not good if they are avoidable.
Right. And if we can do something to avoid them beforehand, then they don't
Hmm.
happen. But
Hmm.
more and more, it gets hard to do that. So I want to go back to the section's mission statement because there's a lot to unpack in there. And I do recall it was very carefully worded. So the mission statement is the Reproductive Health Section seeks to advance excellence and clarity in emergency department reproductive health care by empowering emergency physicians through evidence-based protocols, education, advocacy, and leadership. The term reproductive health care refers to medical issues related to reproductive and sexual health that include ectopic pregnancy, early pregnancy loss management, pregnancy of unknown location management, counseling for and provision of contraception, emergency contraception, management of pregnancy related complications, including prepartum, peripartum, and postpartum complications, pregnancy options counseling, and sexually transmitted infection screening and treatment. We commit to ensuring that all patients receive safe, legal, patient-centered, evidence-based, and high-quality care while upholding ACEP's commitment to emergency physician leadership and professional autonomy. So there's a lot to unpack in there. What are your comments regarding why this was worded this way and the importance of what it says?
Well, I think reproductive health care may feel coded and vague, and people might have different ideas about what it means. And so the group that probably about 40 to 50 physicians across the country got together to work on this, which is pretty cool given that we weren't a section yet. And we wanted to be really clear about, how does this, which I think, some naysayers might say, look, this is not our job, right? My job is just to keep people alive. But we wanted to say, listen, there's a lot of this that is just, this is what we see. This is what we do, right? We do pregnancy of unknown location management every day. We do ectopic pregnancy and STI testing every day. We provide emergency contraception, certainly to victims of sexual assault, but also in other situations, right? Pregnancy-related complications, preeclampsia, eclampsia, abruption, trauma. We want to be the section that people come to when they want to work on any of these issues. And we really just wanted to also make it clear that this is emergency medicine. I mean, like it or not, again, and I think anyone would be pretty hard pressed to say that this is not emergency medicine.
Yeah. And what I see in that section is what patients are coming to me for. It's not
Hmm.
anything that I don't see already. I'm not opening up a clinic to do anything else. This is what comes to me. And
Hmm.
we're the only ones there many of the times. And especially going forward, we need to be there for our patients.
Yeah, and I want to tackle contraception really quickly. I think that there are some people who would say like this is not my job, but then I want to remind us like, and maybe these people are all being seen by APPs and fast track, but how many people come in for STI testing, right? Those people are having unprotected intercourse. These are, if nothing else, those encounters are opportunities for a conversation about whether that person wants to get pregnant. I think expedited partner therapy, we would love to have that be something we kind of work on out of this section. I think that has a huge impact. I just think there's so much we can do, and it doesn't have to mean that you aren't doing all the other critical care that you are providing every day. It's just like, how can we use the few minutes that we're in the room to do a little bit better?
Yeah. I always find it interesting. Every teenager who comes in for one of those things, I say, "Are you trying to get pregnant?" And they say no. And I said, "Well, you're having unprotected sex. So biologically, you're trying to get pregnant." And I think that really makes them think about it in a different way that might impact their whole life. And it took me 5 seconds to say that. So
Hmm.
really just having the confidence and the knowledge to speak about what is in our core skill set can really help.
Hmm. Yeah.
So lots of stuff going on. Starting the section, what are the key priorities that we need to accomplish over the next couple of years that we need members' help with?
Yeah, so first of all, we really want to build our core membership, right? I want to get everyone who cares about this issue in the section engaged and signed up, and I want everyone to know what we're doing. So if this is a passion project for you, or this is something you're interested in as a resident, as an attending, you're in your retirement and you're like, but I care about this, right? We are here for you. So we really want to be the space that people gather in to tackle these issues because ACEP as an organization is extremely well poised to basically move this work forward, right? We can do this piecemeal in silos and it will take 100 times as long as if we do this through organized medicine and use that power to build change, right? So I think first and foremost, we want to create the living room that everyone gathers in to talk about these issues, to exchange ideas, to share information, to collaborate, to move things forward. I think that is absolutely number one. Um, and then number two, in terms of like my specific, like what do I think is the lowest hanging fruit and most important thing for us to focus on right now, I would personally pick early pregnancy loss care. I think there have been advancements in understanding the diagnosis of early pregnancy loss, advancements in our understanding about medication management. There's an exciting work that Team, Access Bridge, Feminem are all doing in this space. And I want to find a way to take all that good work and to spread it faster so that we can all do better for our patients. Um, you know, while the laws have changed, I think to some extent, when people are not providing care that we could be providing, it is sometimes less about the law and more about our lack of training. And when people want to blame the law, I think it's actually often about fear of the law that is maybe not fully reality. I can at least speak for Texas that um, which is right, one of the most restrictive states in the country, once the fetus has died, all care is legal. It doesn't matter how that fetus died. It doesn't matter if they had a medication abortion. It doesn't matter if they had a surgical abortion. It doesn't matter if this was a spontaneous abortion. All care is legal. And so if anyone is trying to say, I can't do it because I'm afraid of X with the law, then we need to treat that fear because there's nothing illegal about miscarriage care in Texas. And I think that is likely true in the other states. I am not an attorney. This is not legal advice or guidance or anything. Um, but, I think we need to, this is where there is a lot of confusion and fear. And so I think, again, a place that organized medicine is helpful is just being a place to educate our peers that, hey, listen, despite everything crazy you see on the news, like this care is legal. We can do this care. This is within our scope of care. And so this is such a common ED complaint, right? We know from the Benson et al. Study that 900,000 women visit American ERs every year for early pregnancy loss associated care. Of those, about 250,000 are diagnosed as early pregnancy loss. That is a lot of people we can impact, but only if we really figure out how to team up together and work on it as a group.
Yeah. And like you said, there are some uncertainties, and we definitely need to help those patients and pass the baton or keep it within us, depending on, if there is even any care in your area, if it's a maternity desert. But once these are done, we need to be able to act decisively because in that time, there can be a lot of complications that we can stop and we can really help these patients. And
Mhm.
I got to tell you, I love how comfortable you are in your legal environment, but the biggest tragedy to me is if a physician knows what to do, knows what is best for the patient, and can't do it because they fear legal repercussions. And I just took the Hippocratic Oath again, which says that I will do legal care. And it's just tragic to me when we can absolutely save these patients and our hands are tied. So knowing when that does not happen is absolutely imperative right now. And just that message alone will save so many lives.
Mhm. And I think, you point out that I am comfortable in my legal landscape, and that is, I'm probably a unicorn or something in that way because I've spent so much time working on it. But what we have learned is that without education, there is a lot of uncertainty and a lot of lack of confidence about what care can be provided and what care is legal. But we've also learned through extensive work in our state that when doctors teach doctors what is legal, what is appropriate, that we get up to like 98% confidence and knowledge. we are working on publishing this data right now, but I spent my last year with my colleague, Dr. Priya Galani, traveling the state, and we've taught 1,500 emergency physicians across Texas between the two of us. She took on more of the corporate environment, and I took on all 20 ACGME certified emergency medicine residencies, and I spoke in person from February of 25 to January of 26, March of 25 to January of 26. And it was so cool. Highly recommend going to visit all of the residency programs in your state. I mean, it's just like so interesting to see how everyone does things differently, and how hard everyone is working to train the next generation. Um, but we also learned, that without, when you change a law, you can't just expect that doctors in their downtime are going to understand how it works, right? And so
Mhm.
there really was a lot of uncertainty and fear. But when we look at surveys after the educational intervention, people got it and people were grateful everywhere. I think on all sides of the political spectrum, right? Because there's enough uncertainty in emergency medicine as it is. We don't need politics messing up the craziness of the ER. So I cannot say enough about how important I think that work is if you are in a state with restrictions where laws have changed, that education is just an essential tool. And I would love for this section also to be a place where we kind of share that education and see how it transitions across states. And I do know that Access Bridge, Feminem are working on that in many states.
Yeah. Do you mind just speaking a little bit about the collaborative partners that you're working with in case anyone interested in joining this section has not heard of the other ones, and
Yeah,
might be
yeah, yeah.
interested
So
in contributing to them as well?
yeah, I think this is a yes and, right? Like this is all the places. Um, Access Bridge started in 2023, 2022, 2023. I'd have to check myself. Um, Out of an organization called California Bridge, which was this bridge was initially this organization focused on Suboxone bridging after opiate overdose from the ER, right? A warm handoff into harm reduction work around opiate addiction. And those same people after Dobbs said, well, could we do that same warm handoff, improving work in the repro space? And so they started this kind of sub thing under Bridge called Access Bridge. Access Bridge has, I don't even know how many fellows a year now, but it's about a 10-month training cohort where you get a assigned mentor. There's a monthly lecture covering core content. They've developed a bunch of algorithms that are super helpful when you're working and you need to outsource your brain to like something much easier. So they have an ectopic algorithm, a PUL, pregnancy of unknown location algorithm. They talk about contraception initiation. They also do talk about medication abortion in the ED, but they really cover this whole span of reproductive health care and train their fellows not only in the science, but also in the how to do change work. And it's an incredible community of people who are invested and really trying to do the work boots on the ground across the country. Feminem, I was having babies during Feminem 1.0, so I missed Feminem 1.0. I like knew about it, but I wasn't involved. Feminem 2.0 is being rebooted to be a home for women in emergency medicine and all the things related to that, right? Gender pay gap, professional advancement, reproductive health care. That is actually, Feminem is where the grant that supported Priya and I speaking across the state was housed. Feminem really provided all the support for getting us on the road, administrative support, managing the grant, really facilitating and creating the slide deck. So very, very, and I am personally indebted to both Access Bridge and Feminem. They are both outstanding organizations that I think everyone should support in addition to ACEP. And Feminem has some great free CME modules on medication management of early pregnancy loss, on contraception initiation in the ED. That you can go and you can watch them. They're like a few minutes long. They're great. Dr. Jalen Avila has a bunch of videos on there looking at, your ultrasound skills related to early pregnancy loss diagnosis. So it's just a great place, and we'll have to figure out on the back end, like, how do we share? What are the rules around sharing external sources, openly as resources on the ACEP section page? But even if you have to go click elsewhere, these are just excellent groups doing really cool work.
So feminine and then teams, you said.
Yeah, team, thank you. Oh my gosh, I feel like I always mess up the acronyms, so give me a second because I'm gonna actually remind myself. Yes, training, education, and advocacy in miscarriage management. So the ER physician lead for that project is Dr. Kelly Quinley, who's a Cal ACEP board member and friend and ex-resident colleague. And they are doing really cool work. If you are in a place where you have an OB department and there's interest in collaboration between OB and EM in improving miscarriage care, they will come out to your site and work with your departments to get everyone on board with manual uterine aspiration. A lot of miscarriage care DNCs happen in operating rooms using an aspiration device that involves wall suction. That costs thousands of dollars more than using a bedside manual vacuum aspirator, that also cuts out the cost of going to the operating room and anesthesia and the PACU and right, like all these other resources that get used when we move miscarriage care into the operating room. And so I know that they're actually coming out to train our departments in May. I'm super excited, and we are going to try and do a real quick and dirty little study. It just so happens they are coming the day we have our Halo training for our residents. Help me out. Do you think most residencies now kind of use the Halo framework for procedural training, high acuity, low occurrence procedures, and grouping them together, like doing your Crike's pericardiocentesis, all of that transvenous pacing on one day?
I would probably say yes from my experience. However, I've not been involved particularly in any of that sort of training recently. So I think I mean, that's what we did. We had procedure days. So now
Day,
it's,
right? And so
yeah.
I think post my time in residency, also, I graduated in 2012, like um, this concept of Halo, at least I became aware of it after residency. So high acuity, low occurrence procedures. And ever since I've been kind of more head in the repro work, I've thought, well, if ER doctors are ever going to learn the skill of manual uterine aspiration as a potentially life-saving procedure for a woman in hemorrhagic shock when OB is not around in the setting of early pregnancy loss, um, I love team, but if we're relying on team to go department to department across the country, that will not be a sustainable way to train people. If we really think this is an emergency medicine skill, it has to be integrated into residency training. And then where do
Mhm.
you put it? And I think it fits into a high acuity, low occurrence procedure, right? And so my hope is that we can show on a day where we're doing a procedure day where the residents rotate through all the stations, that MUA makes sense, that we can teach it, that people feel more comfortable. We're going to look at kind of attitudes around it as well. But it's really not a technically hard procedure. It's potentially life-saving. I don't think it will be done by ER doctors all that often, although, again, in a setting where you had time and felt comfortable with the skill, one could offer it to stable patients with early pregnancy loss. Um, it's certainly more effective than both expectant and medication management. Um, Many people are going to say, I don't have time for that. That's fine. But I think there's some places that this could go. And so they are coming down to train our residents in May, and we will see what our little educational survey looks like after that. But I would love this group to also think about, how does this fit into residency training? Again, if this is in our scope of care, how are we going to teach people about it? Where does it go?
Yeah. So getting back to the section, because so many great things and great ways to get involved, what do you imagine would be a great thing for new members to do? What can they expect in the section? What opportunities? It sounds like there's training, there's teaching, there's advocacy, there's just public announcements. What would you envision that this section needs more membership to do and how to get involved?
Yeah, I want to hear what other people are interested in, and I want to build this organically. And I'd like the section to be a space where um, people have a platform to share the work they're doing. So you have a paper that is getting published and you want to tell people about it. You just gave this great lecture. You are doing this cool research project. Like, we want to create webinar spaces that people can tune in for, and I'd love to record them so that you can listen to them on your jog at 2x speed, right? As ER doctors do. And
Don't tell my professors I do that.
and I hope to, I think figuring out how do we just slowly but surely, methodically move this work forward. There is more than enough work to go around. And so if this is inspiring to you, we will find a place for you. There will be places. I have a feeling that there is going to be more and more need. Right after this ACEP, we will have a counselor slot open the following year. So we'll need representation at LAC. We already had a post just the other day because there is a nursing group that wants an emergency medicine representative for some working group. I'm blanking on the exact need. Um, I know because of ACOG's work in Texas that ACOG is going state by state and making hospital protocols and toolkits to help guide legal care. I would love for us to be able to collaborate with organizations like ACEP through this chapter with the blessing of the board. Lots of goals here, but there is a lot of work to be done. Um, and I hope that especially young members kind of, there's this crazy lurch thing that happens after residency. You've been a learner your whole life, right? And then all of a sudden you have a job. And then you realize that actually medicine just keeps changing and evolving really quickly, and you have to keep learning. And sometimes I think you miss that, like, feeling of being a part of something exciting. And I hope that this is a home for the people that this resonates with, that this is exciting work that is meaningful and the ability to impact patients far outside of your own ED. Like, that is what this section is. I really think um, we are an issue-based section that is not about us. It's really about our patients. And I'm really want to keep the patients centered in all of the work we do. That is who we are doing this for. Um, and I'm just really excited. I'm really excited about what we might be able to accomplish.
Absolutely. And certainly, I work closely with my ACOG delegation in my state society and have made some wonderful connections advancing care in our state. And sounds like an issue that we need 50 state representatives because it's different in all 50 states and the landscape is so different. And getting access to care outside the emergency department and what we need to be primarily responsible for and what our resources are outside are drastically different, and even within the state. So great opportunities here. Getting the section off the ground. So get your membership in, go to the ACEP website, go under your member profile and go into section memberships and click that. Don't wait till the next time that you renew your membership because we're getting this started. It's ACEP's newest section. Come be a part and get the ball rolling. So much to do. Thank you so much for being here, Lauren. I really enjoyed it.
Thanks so much, Laurel.